Okay.
All right, so it's going. Okay, cool. So I know in lecture we kind of, because you all seemed like you were sleepy, like you were worn, beaten, battered, and scorned from the exam.
Yes.
So no one really looked at the raising the bars or anything. So I'm hoping that you guys did that after lecture, or at least sometime this weekend. So we did talk a little bit about hyponatremia, and I know that Miss Pritchett kind of covered that with dehydration, right? For those that were in lecture, were all of you not there?
I wasn't, but
Okay.
Our group was in Miss Miller's class for Miss John's lecture.
Okay, so did you hear, did they go over the dehydration for PD?
No, not really.
Not really.
We didn't get through very much at all.
Oh, okay. Because I covered, instead of all of the electrolyte imbalances, I did the renal failure, volume overload, and volume deficit. But I covered a lot over that piece because that's usually one part that kind of gets skipped over. So I wanted to make sure that I covered it. But anyways, so let's look back. We'll just kind of backtrack a little bit. And I think you can kind of tie some of, try to get notes from somebody that was there that day, Jenny. So that way you guys can get caught back up.
I think we have somebody that recorded it, so we're going to get that from her on Tuesday.
Okay, great. Okay, great. All right, so let's look at, we'll start with sodium because it's usually a little bit more easy to understand. So we'll speak more specifically about hyponatremia, which is basically low sodium where? Where's the sodium low at? If it's hyponatremia. So hypo means under or below. Natri means sodium. It's the prefix for sodium. And then emia means blood. So it's basically low sodium in the blood. Normal range is what?
135 to 145.
135 to 145. So anything less than 135, that's going to be hyponatremia, okay? So where does sodium normally exist when we're looking at it from an intracellular and extracellular level?
Extracellular.
Someone tells you to do something, or I tell you, you should just do it without. or what is it? Are you practicing for fucking? Are you practicing for Halloween or something? That's what it is. Then I mean, I don't understand that. But you ain't you gotta calm down with that shit.
Oh, can you mute? I can't even say it straight. Can you mute your phone? Ooh, that was scary. Okay.
I think it would be helpful for the people who are on phones to mute, because last time there was a lot of feedback from the speakers. So if they could mute unless they're talking.
That would be great. Can we have everybody mute their phone? Hang on just 1 second. I need to mute mine too. Hold on.
Okay. How would I do this on the computer? Okay. Okay, mute.
Sorry about that. My kiddo was asking me a question. Okay, so normally where is sodium located? Is it more intracellularly or extracellularly?
Extracellular.
Is it on the outside or the inside? When you're looking
on the outside.
Isn't it more inside for the sodium?
Outside.
Okay. So if you have low sodium in the blood, then that means there's low sodium extracellularly. So it's not enough to do the job that's needed, correct? And so primarily, where would you see that deficit in the patient? What would be their biggest or the biggest impact that low sodium would have on an individual?
Thirst.
Besides thirst, before that? Your brain cells?
Confusion.
Confusion. So if someone has hyponatremia, then they're going to be confused. So it affects all cells everywhere, but it specifically or especially affects cells that are in the brain. So the most common sign or symptom you would see from an individual would be confusion. So what usually happens when we have hyponatremia, then what's going to happen is the sodium is going to literally shift inside the cell and cause it to get bigger or smaller.
Water follows sodium, so hypo makes it. Wait.
It's either going to swell or shrink. One of those S's. Which one?
It will shrink when there's low sodium. It shrinks.
It actually swells. So when you have low sodium, it expands the cells and it causes them to burst. When you have hyponatremia, because it's actually it's filling up in the cell. So there is very little left in the blood. So there's none outside. It's more inside. And remember, water follows wherever sodium is. So as that sodium's in there, the water follows it too. That's the second reason why you have the swelling. So there's different types of hyponatremia. So you can have hyponatremia and your overall volume status will be fine. So usually the body's water is increased, but the sodium level stays the same. So there's no edema. So there's no dependent edema or anything like that. But what happens when the body's water increases, it's kind of is similar to what happens when you have water intoxication. It dilutes the sodium. So the sodium becomes more diluted. And that's because there's an increased water volume, but not necessarily a decrease in sodium volume. So the sodium's low because it becomes diluted. So a condition that you would see that happen in would be the syndrome of inappropriate antidiuretic hormone. That's where your antidiuretic hormone has a higher secretion, or it secretes a lot of ADH in the body, causing the body to hold on to water. So we have more water in the body, which means our sodium's going to be diluted. Does that make sense? You're still thinking there?
Yes.
Okay. With when you're treating DI, the vasopressin, the hormone replacement therapy, if it's too much, then it can actually decrease the sodium. But more specifically, if you're going to try to link the natremias to DI and SIADH, then here you would see the low sodium, and a cause of that would be SIADH. Renal insufficiency and Addison's disease. So another type of hyponatremia could be hypovolemic hyponatremia. So both the water and the sodium levels are down. So here our patient would be hydrated or dehydrated.
Dehydrated.
They'll be dehydrated because now we're losing blood volume. We're losing volume completely from both water, and we have no sodium. Okay? So when vomiting, diarrhea, excessive NG suctioning, a person gets burned, because burns usually have materials shift from the intervascular into the interstitial spaces. Those would be some reasons why a patient can have hypovolemic, hyponatremic, or hyponatremia. So we can have hyponatremia with 3 different processes. One where the patient's volume is okay, one where the patient's volume is depleted, and then the next one that I'm going to talk about is when the patient's volume is increased. So we're still talking about sodium being low, but we're also talking about the patient's total body of water as well. So here we have an increase in both sodium, and we have an increase in both in water. So this, now the patient has volume overload, the sodium still becomes dilute. Now you do see edema. And the reason why is the patient's total body of water and their sodium are regulated independently. They don't move necessarily together. So we still end up with a dilution of the sodium, but now we have extra volume. So patients that are seen in that type of situation will be your heart failure, your renal failure, someone that's received too many IV fluids, and someone with liver failure. Does that make sense? So think about your liver failure patients, or even your kidney failure patients. They do retain a lot of water, especially your kidney failure, because they don't pee out a lot of water, especially if they have end-stage renal disease. So if they drink fluids, the fluids have no way to go out because the kidneys don't work and they don't regulate it out, correct? But it still affects their their sodium, because although they have that extra fluid, the fluid's diluting their electrolytes. Until they get dialysis, then we can clear it and make it balanced. Does that make sense? Okay. If not, someone speak up and say, I don't get it.
It does make sense.
Okay. All right. So, there's several ways you can try to remember it. I mean, you can look at if we have sodium excretion, if that's increased, then that's usually, NG suctioning, vomiting, your diuretics, diarrhea, your aldosterone secretion, because it's going to waste the sodium. We can have volume overload. So like your heart failures, your hypotonic solutions, your liver failures, we're still going to end up with hyponatremia, but our volume status is different. If you don't take in enough sodium, so you're on a low sodium diet, or if your patients are MPO status, especially your elderly, then we're going to have to monitor their sodium levels for decreased sodium. Okay. Antidiuretic hormone, the biggest issue there is going to be SIADH. So outside of confusion, which was one of the things we talked about initially, what other signs and symptoms would you see with hyponatremia?
It could also lead to seizures, ultimately.
Okay. So they can have seizures. They can have, confusion. They can have cramping in the belly. They're going to be really, really tired. Loss of urine and appetite. Their reflexes are going to be decreased because they don't have the sodium. So they may have difficulty concentrating. Their blood pressures, they can have orthostatic hypotension, so positional changes. Now their blood pressure is going to go down. Vowel sounds might be hyperactive or overactive. Respirations will be shallow, but this is going to be a late sign because of the skeletal muscle wasting. And then we can also expect for them to have muscle spasms. So all of those things are kind of normally seen with hyponatremia. So we want to watch from all of these things that we talked about, we want to make sure we're monitoring their cardiovascular, respiratory, neuro, GI, their renal status, all of those things we want to make sure are working. So their BUN, their creatinine, their level of consciousness, if they have any abnormalities in their rhythms, if their respirations are shallow, what their blood pressure may be. So, do they have diarrhea? Those are things we want to be looking for.
I think they also said restlessness and irritability.
Right, and that's attitude changes, or you can do level of consciousness changes, however you want to put that. Okay, other things. So the first one we talked about is the person that has normal volume. For if they have normal volume, then the only thing we have to manage at that point would be their sodium. But if they have low volume in the body system, then we're going to have to manage that. So usually when their sodium level starts hitting those critical levels, like in the 120s, then we want to think about giving them something intravenously to help get the sodium and the fluids increase. But we just can't give it to them really fast, because then we can actually now throw them on the opposite end. So we give it to them.
You just muted while you were talking, so we didn't hear like half that sentence.
Dang it. Thank you for telling me. What did you last hear? I'm just talking away.
You said you had to give it to him slowly because you could throw him to the other end of the spectrum if you gave it too fast. That's the last thing I heard.
Okay. So what IV fluids would that be? Because we can't give them anything PO. That's not going to get it up quick enough. So we have to give them something intravenously. So what IV solution? Would it be isotonic, hypotonic, or hypertonic?
Isotonic.
We're talking about critical levels when they hit that 120s. If normal's 135, so when they start hitting in that 120s to the 110s, what do we want to give them?
Is it 3% saline?
It is the 3% saline. So I'm not against the isotonic if their levels are, not less than 125, that's fine. But I would still give that slow, because you still don't want to don't want to have them now instead of the cells swelling, because the whole point of giving them this hypertonic is to actually pull the sodium out of the cell and back into the extracellular environment, correct? Correct? Because we just went from cell swelling, so now we need the cell to shrink. So if you're giving 3% saline solution, you might want to do it via central line. It's really hard on the veins, or some type of big IV. And if they're giving it peripherally, then you really need to monitor it closely. So its job is basically going to be to shrink the cells, pulling the water out and causing the fluid volume, the fluid volume overload if we do it too quickly. That's why I said you don't want to switch them to the other side. All right, if they're hypervolemic and they still have sodium issues, then how are we going to treat that? So this was the one that was hypervolemic and they had low sodium. So like your CHF patients, your renal patients, what do we want to do for them? What do we do now when we're in clinical and we have these folks? Do we give them a lot of fluid?
No, we don't give them a lot because they can't excrete them.
Exactly. So instead of giving them fluids, then the best thing to do would be to restrict the fluids. And depending on the person, they may receive some diuretics to help pull fluids off unless they're in renal failure. If they're in renal failure, then they're going to get dialysis because the extra water, we're going to try to get rid of the extra water and try to conserve the sodium by giving them the diuretics. So that's one option to treat them. What about your folks that have syndrome of inappropriate antidiuretic hormone? How are we going to treat them? And we're just speaking from a sodium standpoint, not necessarily the disease condition itself. Are we going to give them a lot of fluids? So let's think about syndrome of inappropriate antidiuretic hormone. If you have antidiuretic hormone, what does that mean?
It means you're retaining fluid.
Okay, so your antidiuretic, you have your diuresis that everyone does. So now your homeostasis system, which is the antidiuretic, its job is to help you not pee a lot, right?
Right.
So if you have syndrome of inappropriate antidiuretic hormone, then what's going on?
You're retaining a lot of fluids.
Okay, so since we're retaining fluids, do we want to restrict fluids, correct?
Yeah.
Correct.
So if they're retaining fluids, we don't want to give them extra fluids. We want to restrict the fluids. We want to give them the antagonist, so the antidiuretic hormone antagonist, so that they can pee. And one common medicine that we can give with that would be declomycin, so DECLOMYCIN. It's one of the tetracyclines. But we don't want to give it with food, especially things like antacids or our dairy products, because it's going to bind to the cations and prevent you from having effective absorption of the medication. So when we're giving them that declomycin, that'll be one thing we want to tell patients, don't take with dairy products and don't take with an antacid. Okay. What about patients on lithium? Do we care about them?
Yes, because isn't that sodium bicarb?
So here's the key or the problem. Patients on lithium, we need to monitor their levels because the body's going to conserve the lithium, and it won't be excreted well when the sodium levels are not in normal limits. So now they're going to retain the lithium, which is not a good thing. So give me some foods that are rich in sodium. Since we have hyponatremia, what would be some foods we could tell them to take or to eat?
Cheese.
Cheese is a good one.
A lot of canned foods.
a lot of canned foods, because we talked about that in class. They're loaded with sodium. I don't know if I would go as far as saying those ramen noodles, but because those have about 1,200, 1,300 grams of sodium. But, you know, canned goods, cheeses, bacon, hot dogs, any processed foods, any processed lunch meat, any of those would be appropriate, including down to table salt, which is the one thing they tell you, don't do table salt. But this would be one of those times in hyponatremia. Okay? Now, don't tell somebody to swallow a whole thing of table salt. Don't do that. So just be mindful, you know. I would probably stay away from that one and mention the other ones. But just think of high salt content foods. Those would be the ones that I would educate the patient on, you know, consuming if they're having issues. So any questions with hyponatremia? Because if not, then we can slide on to the opposite, which is hypernatremia. And so now we have increased sodium levels in the blood, right? Or excess, so it's greater than 145. And so again, this particular electrolyte helps us regulate water inside and outside the cell. And the two of them are pretty much, you know, they like to be around each other a lot. So here, when we have hypernatremia, then it's going to affect the cells everywhere. But now we have more cells or more water and sodium that's actually in the extracellular fluid than the intracellular fluid, correct?
Yes.
So now we have the cell shrinks versus it being swollen.
Yeah.
So when the cell shrunk, then we're going to have hypernatremia, and things that can cause your hypernatremia would be what?
Of course, consumption of too much salt.
So high salt intake, okay. Whether it's IV
yeah.
routes or you're taking it by food, what else?
Dehydration can
Doesn't
cause.
matter. You're talking about the fluid to treat dehydration. Because here we have hypernatremia.
Okay. No.
Yeah, we have hypernatremia. So what else? So what if you give somebody a tube feed and they don't have the appropriate water supplementation after the feeds? Then they can develop hypernatremia. Too much of the hypertonic saline solution, they can now have hypernatremia. If we don't excrete out sodium, like if you're on corticosteroids, Cushing syndrome, that can also cause it. So you have hypercortisolism, and that's because the increased cortisol causes the sodium to be increased. You're right, loss of fluids, dehydration, you were correct on that. You should have stuck with it. Fever, sweating. You're like, I don't know. Aldosterone, no, you're on point. Aldosterone issues, so it increases the reabsorption of the sodium. And then they would be thirsty. You did talk about that already, that they have thirst impairment or impaired thirst. So should we tell them to eat some fried foods?
No.
And then all those foods that we just talked about, that's high in sodium, the canned goods or canned foods, processed foods, lunch meats, bacon, hot dogs, all of those would be the foods you would tell them to do what? Avoid?
Avoid them. Yes.
Okay, so tell them to avoid them. All right, so if we have hypernatremia, then, you know, what kind of signs and symptoms will our patients have?
Dry mucous membranes.
Yep. Dry mucous membranes, both
Yeah.
mouth and skin. So that would be the person when you do the skin turgor test on them, the skin would stay what?
Tinted.
It'll stay tinted. Okay. What about their urinary output? Are they going to be peeing a lot?
No, they're going to have decreased.
Nope, they're going to have decreased urinary output, but they're going to be edematous though. And they can, in some cases be extremely confused. So fluid retention, edema, agitation, they could have a fever, flushed skin. Those would be your signs and symptoms. So since we have a lot of sodium, as I said, we want to restrict sodium intake. Because of the confusion, there'll be a fall precaution. So we want to make sure, following the appropriate facilities, management of fall precautions, whether they're the yellow socks, call before you need to get out of bed, all of that. What type of fluid would you expect your physician to order this time?
0.45 normal saline.
So half normal saline, or they may order them isotonic. So they may order normal saline. Again, we don't want to give that half normal saline, fast. We want to give it slow because we're trying to hydrate the cells, right? And if we give it too quickly, then we can cause them to develop cerebral edema. So that we don't want them to shift too fast. So if we give it too fast, then they can end up with cerebral edema. So now we've just made their situation worse. So education-wise, things we're going to tell our patient outside of these other interventions is to avoid the foods we've already talked about and to, look for signs and symptoms of if they think they may be having an increase in sodium levels again. So impaired thirst, loss of fluids, dehydrated, fever, the skin that's tinted, dry mouth, fluid retention. So that would be all the things to tell them to look for. Are we cool on that one?
Yeah.
Okay. All right, so let's look at some potassium. So we'll start with the low one first. So hypokalemia, low potassium in the blood. So more potassium lives inside the cell than outside the cell, correct?
Yes.
So when we have hypokalemia, then we're going to shift it into the intracellular space, and we're going to leave very little on the outside or in the extracellular fluid, or basically in the blood. So our potassium is responsible for our nerve impulse conduction, muscle contraction, and if we don't have enough potassium in the blood cells to use, then we're going to see problems with our GI system, problems with our renal system, problems with our lung muscles. So we're not going to be breathing as well. We're not going to put a lot of effort into breathing. And we're primarily, the biggest concern is we're going to see problems with our heart. So they're going to have what they call arrhythmias or dysrhythmias. So abnormal conduction is what we're going to end up seeing. So causes of having hypokalemia would be if we are on taking a bunch of diuretics. So, and especially if you don't need it. So you're trying to lose like water weight and you take like your grandmother's water pill, that'd be the most stupidest thing of all time to do. But people do it if they're trying to, get some extra weight off. I don't understand it, but then you run the risk of having an arrhythmia and now you're wondering what happened. But laxatives as well. So, the elderly patients, I got to have that bowel movement every day. I got to have my bowel movement. So they'll take an X-Lax and then, it may be too much for them. Corticosteroids can also cause hypokalemia. Inadequate potassium intake, so the patient may be NPO, or maybe they're anorexic, or maybe they're not feeling well enough to eat, or maybe they're too nauseous to eat. So those are all kinds of issues. Cushing syndromes with the increased aldosterone secretion, a lot and lots and lots of fluid loss, like if you NG suction somebody, vomiting, diarrhea. What if they had abdominal surgery and had to have a wound back on that? You need to watch their potassium levels, because remember, you see a lot of problems where potassium is rich, and it's rich or needed in the GI system, the heart, the renals, and the lungs, right? So other causes could be that the potassium shifted from the extracellular to the intracellular space, like when we have someone in metabolic alkalosis. So they have too much insulin in the blood, so they have that's available. So if you have too much insulin on board, are you hyper or hypoglycemic?
Hypoglycemia.
You have hypoglycemia. Okay. So glucose and potassium, they like each other, kind of like sodium and water. So if the glucose is low, then more than likely potassium is going to be high or low.
No.
It's gonna be low.
But ma'am,
Yeah.
in Cushing syndrome, the glucose is high, right? But Cushing syndrome and steroids, they lower potassium.
This is more on the aldosterone secretion component. Because if you have Cushing's, don't you have an increase in cortisol levels? Doesn't that release more aldosterone? So it's the aldosterone and the sodium that we're matching together, not the glucose and the potassium. But I know what you're saying. And if you have that, if you're taking corticosteroids, that's if you're taking it, then it will cause your glucose levels to go up. That is the norm. An exception to the rule, it can actually cause it to go the other way. But you're trying to link the glucose and the potassium together versus leaving it as, in Cushing syndrome, we have hyperglycemia, which is true. However, we also have an increase in aldosterone, but we're speaking only specifically on the potassium. We're not speaking on the glucose.
No, but I just don't want to just put in my head that whenever glucose goes up, potassium also will go up because then there's an exception in Cushing case. That's why it's for exam purposes. That's why I'm just a bit.
Right, but keep each of the conditions separate. Don't put them together. So in Cushing syndrome, we're still going to have hypokalemia, and you would still have hyperglycemia. That's true. However, if you have hypoglycemia that has absolutely nothing to do with Cushing's, then you're going to have hypokalemia.
Okay.
Does that make sense? I know you're trying to pair them together, but for this particular portion of the lecture and for testing purposes, keep them separate.
Okay.
So only look at if I have hypoglycemia, then I probably need to have my potassium checked to make sure I don't have hypokalemia. But if I have Cushing syndrome, completely different process, then I'm going to still have hypokalemia, but I'm going to, instead of having hypoglycemia, I'm actually going to have hyperglycemia. Does that make sense?
Yes, ma'am.
So don't push them together. It's the same thing what I told the class about sodium and SiADH and DI. Don't try to couple them into the hypo and hypernatremia in the hypo and hyponatremias, because although those are causes, you can have those conditions without DI and without SiADH. Does that make sense?
It does, ma'am.
Okay, so everybody that has hyponatremia doesn't have SiADH, or anyone that has, hyper doesn't have, DI. So you just have to look at the condition. So when you're reading the test questions, just understand there's an exception to the rule. All conditions won't fit that process. So just know how they work. This is probably one of the most rote memory tests, because you either have it or you don't. You either fix it this way or you don't. Does that make sense?
Yes.
Okay. So I do appreciate you, bouncing through, because I'm quite sure there's some other folks that had that same concern. Okay. So we talked about what else we cover. So what kind of signs and symptoms would we see? Is this going to be something, fast and high, or slow and low?
Low.
Everything's going to be slow and low. Your pulses are going to be weak. They're going to be irregular. They're going to be thready. They'll probably be slow, right? We're going to have low BP or orthostatic blood pressure. Bowel sounds are going to be diminished. Our reflexes, are they going to be increased or decreased?
Decreased.
Decreased. And so they're not going to respond because the potassium's too low. We need potassium for muscle contraction. So if we don't have muscle contraction, then how are we going to have deep tendon reflexes? So they're not going to respond. When the potassium's critically low, then they're going to end up with the muscles being flaccid, or potentially they can have paralysis of the muscle. Okay. Other things: confusion, weakness, respirations. Remember, those muscles are going to be tired, so they're going to have shallow respirations. Breath sounds are going to be diminished. They're not going to expand like they should because of the muscle weakness, because of the decrease in the potassium. So the biggest thing that usually happens is your, let me see if I can find what I'm looking for. ECG changes. Oh, I'm looking for something that was right here in front of my face. So with your EKG changes, I just want to show you, I'm going to share my screen here for a minute. Oh, hold on. We hit share screen. That would be helpful if I did that first before I go to the screen. All right, so can everybody see the screen here? Let's see if I can make it bigger. There you go. So this is what your ECG tracing should look like on a normal basis. You should have an upright P wave, you should have a QRS complex, and then you should have like a rounded normal T wave. So this here would be your atrial depolarization when the atria contract. Your QRS will be when your ventricles contract. And then your T wave is when your ventricles repolarize. So that means they're getting ready for the next contraction. So with that being said, when does the atria, when would they repolarize?
It's a small wave that's hidden behind the QRS complex.
So it happens in here. So you never really see it because it's pretty much embedded in there, right? Okay. Most people do not have a U wave present, but if they did, it would be this small. So usually if you're looking at most of your normal QRSs, et cetera, then this is what you would see post this point. It'll stop here and then your P wave would pick back up. So we're talking about hypokalemia. So we're going to have a depressed segment in your ST segment right here. So that's one problem that we could see, or an inverted T wave. That'd be another way you can look at it. So here's your ST segment, here's your T wave, and it's pretty low or flattened or inverted. And then this piece here that used to be kind of flat or non-existent is now prominent. That makes sense?
Yes.
Okay. So just kind of understand if you're looking at an ECG, and we're going to talk about ECGs and perfusion. And I can kind of get back to that. But this is kind of the normal up top here. This is normal. And then if your potassium is low, then the three things you're going to have is a depressed ST segment, or a flattened or shallow or inverted T wave, and a prominent U wave. You won't have all three. You'll just have one of the three. Makes sense? You don't have to have all three in order for it to be hypokalemia. Like questions about that? Okay. All right. So the other thing I didn't talk about was leg cramps. So that's usually, leg cramps and limp muscles. Those are usually some of the other signs that are seen. Mostly when people realize that they have a cramp in their leg like a Charlie horse, that's usually low potassium levels or low electrolytes. So if that person gets some Powerade, Gatorade, K10, then that should correct the problem. And do you flex or extend your foot?
Flex.
You flex your foot. Because if you extend it, you're just going to let the muscle tighten up some more. So you have to flex your foot back towards your face and kind of push it up against the wall or lean your body into the wall. Okay? So how are we going to fix somebody that has hypokalemia?
Well,
Well, depending on how low the potassium level is, like they could take an oral supplement or implement potassium foods, like if it's 2.5 up to 3.5 up to normal.
Mm-hmm.
But if it's moderate and low, more critical, then IV potassium.
Okay. All right. So basically, normal potassium is 3.5 to 5. So somewhere in there. And there's, depending different facilities, you'll see something different even in your clinical sites. So don't freak out. All right. So if I have a potassium level that's less than 3.5 but greater than 2.5, then they can give them oral supplements. There's 2 types. So normally we give them those K-Dirts, that nasty crap. It is nasty.
What's it called?
K-Dirt, K-DUR.
It doesn't taste well or what?
It's nasty.
Is that what they say to mix in apple juice because it tastes so bad?
Yes, you can mix it in apple juice. I mean, be nice to your patients, for the love of the Lord. I mean, that stuff is crazy, but they have to take it with food because it causes upset of the GI system.
Okay.
They have another one that's almost, it's an effervescent. It's a powder or a tablet, and you mix it with water. So it usually have like a lemon lime or some type of citrusy flavor. And with that, you would at least, it's a little bit easier to take. So that's a powder form. Okay. But that K-Dirt, that big old horse pill, break it in half. But yeah, it's gross. I've had to take that on an occasion, and I was like, oh my gosh, I'd just rather eat nails than to swallow this crap. If your potassium level is less than 2.5, then we're going to give them, some type of parenteral potassium, correct? Can we give potassium IV push?
No.
No.
Can we give it sub-Q or IM?
No.
Okay, please remember that. Now, when they're getting ready to give you lethal injection, they're not going to give it to you IV fluids. They're going to give it to you straight legit through your IV and be done with it. So, but I don't want you running around giving your patients that. They're not, they haven't been placed on the lethal injection list. So don't do that. So what's the max per milliequivalent per hour you can infuse potassium through in a vein?
10 milliequivalents.
10 milliequivalents is probably about right. 20 is too much. Although some books will say you can give up to 20, I'd be nice to those patients because potassium burns and, it can cause infiltration. It can cause phlebitis. So we don't really want to cause additional, problems to our patients. So as far as, nursing interventions, just make sure it's going at about 10 milliequivalents per hour. If the patient's saying that it burns, I will call the doctor and see if we can push that back to 5 milliequivalents per hour. If it's not going to upset any other lab values or any of their medications, then it just be nice to the patients and do the right thing. Since it is potassium, they need to be on a cardiac monitor. We need to monitor their respiratory and cardiovascular system. We need to also look at their GI and renal, looking at their urinary output. Specifically for renal, we're going to look at BUN and creatinine, right? So we want to make sure we're on point there. The cardiac monitors to make sure they're not having any ectopic beats like premature ventricular contractions, so PVCs. So they're kind of wide and bizarre. So we want to make sure that they're not displaying any of that. One other thing we want to monitor is their magnesium level, because when potassium is low, sometimes our magnesium levels go down with it. And if their magnesium level is too low and you need to give them IV potassium, what do you need to give them first?
Magnesium.
You need to give them the magnesium first, because if the magnesium is low, then it's going to be very hard to get the potassium up. So you may have to give them two IV piggybacks. You may need to give them the mag and the potassium, but give them the mag first and give them the potassium second. But K and mag do kind of go hand in hand. If the potassium's down, then more than likely the magnesium will be down. So just, kind of check those lab values. So when you're in clinical, try not to just only check your your abnormals. Look at everything that's tied to that respective condition. Should we give them Lasix or any of their diuretics?
No, you may want to hold them.
So we don't want to give them any of their diuretics. So if you have a patient that they're getting, say they're going to get, their blood pressure and it has hydrochlorothiazide in it. So it may be lisinopril with HCTZ. Then you might want to call the physician and ask the question, especially if they're having hypokalemia, if he wants that blood pressure medication to be given. He or she may say absolutely not. And that absolutely not may be because of the fact that we know that potassium, most of those hydrochlorothiazides are loop diuretics. They're all potassium wasting or potassium sparing.
Potassium wasting.
They're potassium wasting. So if we already have hypokalemia, we don't want to now undo the work we've been working on and now make their potassium levels lower. Does that make sense? Okay. All right. What about digoxin? Any concerns with anybody receiving digoxin?
It can cause the toxicity.
So like lithium prior to that we spoke on, if our potassium levels are too low, then we're not going to be able to clear the digoxin for our patients. So our patients, and digoxin, does it have a large or narrow therapeutic window?
Narrow.
It's a very narrow therapeutic window. So anything over 2, then we're in trouble, and that could be literally 2 tablets for your patient. So some things that, especially if your patient needs to be diuresed or whatever. So what nursing intervention could you do to help facilitate like part of that SBAR? What could be in your recommendation for something you can recommend to the physician?
A potassium sparing diuretic.
So giving them a potassium sparing, which means they'll diurese, but their potassium will not be lost. So there's several potassium sparing medications like aldactone, spirulactone, diazide, Maxide. Those are all some good ones that you may see. But you just say, can we give them a potassium sparing versus a potassium wasting? And the physician will have his or her option to choose what they want to give at that time. Does that make sense? Okay. So any questions about hypokalemia? All right, so let's talk about some foods that are high in potassium from a dietary measure that we can actually help our patients.
Bananas.
Banana.
Banana, what's that, Chiquita banana? I hate bananas. But bananas is definitely, say that again?
Bananas, potatoes.
Potatoes, yep.
Oranges, tomatoes.
Oranges and tomatoes. Mm-hmm.
Spinach and strawberries.
Spinach, so your green leafy vegetables, strawberries. Fish, that's a good one. Raisins is a good one. Carrots. Pork, for those who eat pork, that wouldn't be me, but for those who do, knock yourself out. That would be some good ones. Mushrooms, I don't like those either. But those are all good ones. Those are all foods that are rich in potassium. So we know the foods that are rich in potassium. So when we get ready to talk about hyperkalemia, those will be all the foods you tell them what not to eat. Okay? So it's not like it's going to change. So the potatoes, the pork, avocados, oranges, spinach, fish, strawberries, mushrooms, bananas, carrots, raisins, and the other one was cantaloupe, so your mushmelons. So any questions with that? Okay. All right. So let's look at hyperkalemia. The heart likes nothing too high or too low where potassium is concerned. So your potassium levels must be within normal range. So if it's too high or too low, then we're going to have issues. So this would be potassium is now more in the blood. So we have too much of it, and it normally lives in the intracellular fluid. So if it's greater than 7, then we are dangerous. If we're alive at that point, then, God bless. But however, potassium is now moved outside of the intracellular, outside into the intracellular space, basically into the blood. So that can happen if the person has burns, If they have any kind of tissue damage or if they're in acidosis, then their potassium levels will be elevated. The last, for hypokalemia, we spoke about Cushing's. So this would now be Addison's disease, where we would see a cause for hyperkalemia. Renal failure, because we can't clear it. Too much potassium intake, so the kidneys the kidneys are not working really well to excrete. Therefore, we hold on to the potassium, and then we're taking potassium sparing versus potassium wasting medications. Your ACE inhibitors will also cause you to retain potassium, and NSAIDs. So that will increase your potassium levels. Signs and symptoms: muscle weakness. Their urinary output, they would probably have oliguria, which is basically low or scanty urinary output. Anuria is no urinary output, or urinary output is absent. And so anuria would just be A-N-U-R-I-A. Oliguria would be O-L-I-G as in go, U-R-I-A, okay? Patients that have respiratory failure secondary to acidosis, so a lot of muscle weakness, they could potentially have seizures. Muscle twitching, because now we have too much potassium in the blood. So we'll have muscle twitching and cramps. And, you know, a late sign of that will be profound weakness of the muscles and flaccidity. The muscles are flaccid. Cardiac contractility is decreased, so weak pulse, low BP. And then I'm going to go back to sharing the screen so you can see hit that one, share screen. And that's probably me. So here in hyperkalemia, these are all the ECG changes that we would have with hyperkalemia. So one would be peaked T waves here. So remember here, it was actually, we had a flattened or an inverted T wave, but now this is our U wave. So we had a flattened and an inverted T wave here. Now look how peaked it is. Sometimes it can supersede the QRS or be just as tall as the QRS. We don't have a narrow QRS like we do here. We actually have a widened QRS. Is this good for it to be this wide from here to here? So this is abnormal. If we have too many of these wide QRS complexes, the patient could go into VTAC or VFib. That's why nothing too high, nothing too low. Our P wave, instead of being kind of, rounded like it is up here, it's much more flattened, and depending on the potassium level, it can it could be absent. So it could be either flattened or non-existent. Okay, wide QRS here. And then we have the peak tall waves here. Then between the Q, this is our QRST. So from here to here to this, the beginning of the T wave, if we measure from this point to this point, that would be prolonged. And then our PR interval, this would be long. So when we get to that perfusion lecture, this will make a little bit more sense when we start looking at what the normal ranges are for those, okay? So some interventions, well, if we're talking about cardiac stuff, so we definitely want them on a cardiac monitor. We mentioned that their respirations would be shallow, right? Is that not what we said?
Mm-hmm.
Okay, so we're going to monitor for that. Muscle twitching, the neurostatus, neuromuscular. We're going to monitor for the neuromuscular activity. And then we have our GI status that we're also going to monitor, right? Because we did say that our potassium was rich in our GI system, so we don't want too much of it. Correct? So those would be all things that we can do to help in that process. Definitely SpO2 cardiac monitor. What if they were already on IV potassium or receiving potassium supplements?
Stop it.
Stop it. Okay. Then we tell them to stop all the foods that's rich in potassium. You know, these folks will probably need to go to dialysis, especially if it's that super critical, you know, hitting that 7 level. Or if it's in the 6 level, then the doctor may order like some K-Exolate, which is a cathartic, and it will help to promote potassium excretion. So it's going to increase the sodium absorption in the GI system, which will actually help the potassium get out better. They may decide to give them Lasix or a potassium wasting diuretic like a thiazide or a loop diuretic to help get the potassium out. They could
Ms.
order.
Hudson,
Yeah, I'm sorry.
on the K-Exolate, does it make them poop a
Yes.
lot?
Yes, they're going to poop. It's kind of like it's a cathartic. So they're going to go to the bathroom. The whole thing is to pull it out, and then they'll poop it out. So they'll take it either PO or do an enema.
What's that? What we're talking about? I missed that.
The K-Exolate, she asked if they were going to poop a lot. So they're going to poop as much as the cathartic allows. So I can't say they're going to have a big poop or, you know, a little poop. I can only say they're going to do a number 2.
Okay, what do you call it? What do you call it?
Oh, K-Exolate. It's K-A-Y-E-X-A-L-A-T-E. K-Exolate.
Okay.
And I did, so on the retention tab for fluid and electrolyte balance, there was like a potassium questionnaire, some pre-test and post-test questions.
Okay.
One of them was asking about the K-Exolate. It said, you know, how is it given? And one answer was PO, the other one was by rectal. I guess it's preferred rectal because taking it oral can cause other complications, I think is what it said. You know anything about that?
If you take it PO, that what can happen?
So I guess the preferred route is by enema through the rectum, you know.
Right. So PR, per rectum.
Right. So you can also give it by PO, but it's not your first go-to route. Is that right?
It'll be physician's preference, but overall, if you're having a problem, more than likely they're going to try to do what they can to shut it down. So they'll probably restrict your fluids or be MPO. So the K-Exolate enema would be a better route.
Okay.
So they're not going to give you anything extra if you're already having a high potassium. So everything will just be IV, but per enema is fine.
So here's kind of an off-the-wall question. If the patient's having a bowel movement because of that enema, how do you measure that output?
How do you measure how much potassium output they have?
No, just the stool output, because it's obviously going to come running.
Well, if it's not formed, then you have a measurement. If it's formed, you can't put a weight to a volume. Does that make sense? So you just describe it as is. But what they're going to do is do serial or repeat potassium levels.
Okay.
And that will let them know if they're excreting out the potassium the way that they want to.
Okay.
Okay. So the other thing they may also add to that is a hypertonic solution of glucose and regular insulin. And I think I mentioned that in class the other day to help get the potassium levels out.
Okay, ma'am.
It'll push hang on one second. It's going to push the potassium back into the cell. Go ahead.
Okay. I want to know now if somebody has high blood pressure issues, and then you has a prescription and order for both ARBs and also for ACE inhibitors. What are you going to do?
Okay, so I got ACE inhibitors. What's your other one?
ARBs and just I know that ARBs also increases ARBs.
Oh, so okay. So your angiotensin receptor blockers.
Yes.
Okay, so if they're taking angiotensin receptor blockers and
or either of ARBs or of ACE inhibitors. if the person also has hyperkalemia, what are we going to do, knowing that they also have blood pressure issues?
Then if the person's having hyperkalemia, if you're taking an ARB, it will actually allow for the conversion, but it will eliminate the effects. So the only thing I'm aware of is ACE inhibitors is having the problem,
Okay.
not the ARBs. But you said ARBs, and what was the other one?
Okay, no ACE. Like, I'm not about any of them. If the person has an order for ACE inhibitors, for instance, and the person has hyperkalemia, what does the nurse do?
Then they're going to order a different blood pressure medication until then, or hold the medication. So they will monitor the patient's BP, but we already said that what would their BP be? What was the signs and symptoms?
Yeah. Or low.
They're going to have a decrease in contractility, so their pressure probably will not be high. But it doesn't mean it won't be. But if it is high, then we could give them like a hydralazine, so you could give them that, or the doctor can change their medication to something different to manage their blood pressure until their potassium levels have come back to normal. So that would be call the MD and ask him what other blood pressure medication he or she would prefer to give until the potassium level returns back to where it needs to be.
Oh, okay.
Or back to normal. But you can't give a medicine if you know a medicine's going, like an ACE inhibitor. If you know the ACE inhibitor is going to be a problem, then why give them the ACE inhibitor? Does that make, I mean, that to me doesn't make sense. But I could be wrong.
Okay.
Right?
Okay.
Make sure I said that right. So, right? Am I not correct on that?
Answer my question, ma.
So your question was about blood pressure medicines, right?
Yes, we
Because ACE inhibitors is the only one that I'm aware of right now that actually helps or causes or your potassium level increases. So if your person is on an ACE inhibitor, then, or even if it was an ARB, even though we'll say ACE inhibitor, we'll stick with that, then we would need to find a different blood pressure medication to manage the blood pressure. So that would be in your S-bar. Part of your R would be to call the physician and ask the physician what other blood pressure medication can we give for this patient until their potassium normalizes. Up until then, we can't do it. And it's all going to be patient dependent. I mean, what if your patient's blood pressure was actually normal? Then you wouldn't give him or her, or if it was too low. So if it was too low, you wouldn't give it to him. But right now we need to treat the potassium issue. So we would hold it and then call the MD.
Okay, ma'am. I just maybe with time, just cross check with these ARBs, the statins, if they cause hyperkalemia, because there's a lot of differing literature on it. They say that ARBs actually cause hyperkalemia. That is the
So
statins.
if ARBs cause it too, and your patient has hyperkalemia, we're not going to give it to him because we're now trading one issue for another. We can give them another blood pressure medication, but we have to now get the potassium levels down. So I would hold ARBs, I would hold ACE, I would hold any other medicine that's going to cause the potassium to go up, because we're already up, so it doesn't make sense to give the medication knowing it's already high and we're going to make it go higher. That doesn't make sense. So they would have to hold the blood pressure medication, as I've been saying already, call the physician, ask for another medication that could be given that doesn't cause potassium increase. But as a nurse, you don't go ahead and give it. It would be no different than if the patient's blood pressure was 100/60 and you gave them the blood pressure medication anyway. So that wouldn't be prudent nurse judgment. So if my patient had a low BP, I'm not going to give them that medication knowing it's going to drop at 10, 20 points, and they could be potentially in the 90s or the 80s. Now I got to call, rapid response team to fix it. Does that make sense?
It does, ma'am.
So, the physician can order whatever he or she so desires. But as a nurse in your nursing role, you owe it to your patient to not cause them any harm. So you're literally the eyes and ears of that physician. You're seeing the patient. You see that there's changes. So it would be almost negligence if you went ahead and you gave it instead of saying, you know what, I'm not going to give this because I know that it causes potassium. It causes potassium to increase. My patient's potassium is high. Even if the patient was teetering just above high, so say the potassium level was 5, it was at the upper end of high. Prudent nursing judgment would be, okay, I'm still not going to give this med. I'm going to call the physician and see if he wants to hold it and monitor the patient's blood pressure, and then give, usually something that they usually give them hydralazine to help bring the pressure down in between medications, or some other med to help bring the patient's blood pressure down that's not going to impact their potassium level. But at this point, we have 2 problems, but we can fix one for sure. The other one, we have to do another series of events to fix. Okay? So, I hope that when you're in clinical, for those of you that are going to clinical, or if you're in clinical practice, that just because the physician ordered it, you can't turn a blind eye, especially if you know it's going to cause a problem to your patient. Does that make sense?
Because if you administer it and they have a problem, you're responsible for it.
That is correct. It doesn't matter whether they ordered it. I mean, you're the one seeing the patient at that time. And if you have cause for concern, then, or even to say, what if you didn't even realize it was a concern? That's still on you, because you should know the medicines. So I appreciate you looking up that process with the ARBs and the ACE inhibitors. But either way, just know that you're still responsible for how all that goes down. So, and that's what I try to implore with my nursing students in clinical, that just don't give something just because the physician ordered it. Make sure if especially it's a blood pressure medication, make sure that you are checking a blood pressure, right before you give that medicine. And you're actually doing a manual blood pressure. So that way can't change what you unsee, hear, and feel. Machines can tell you a whole lot, but you need to make sure that machine is on point. That machine has an algorithm that it's working with. Okay.
I do have a question. When it comes to the regular insulin ordered, that's to put the potassium back in the cell, and then the hypertonic solution is to control any type of possibility of low blood sugar, right? So you would give like a D5
or some have given D50 depending on the situation.
Okay.
But it'll be a dextrose water of some sort.
And how quickly would the body react to that? Like, how long would they have to be on that regimen?
Oh, that's going to be a short-lived process. It's not going to be an all day. It's almost like an acute way to treat it real quick. So the doctors, they're expecting a turnaround on that, within an hour, if not less than that. And a patient, if they have to do that, they need to be in the ICU. Some of these other patients, they need to be in the ICU. So you shouldn't be managing, critical patients like that on the floor. Okay, especially if you're going to be doing all of those things to him or her. Okay, anything else on hyperkalemia? Okay, so we've done hypokalemia, hyponatremia. We can do hypercalcemia, or we can look at, I can, roll up a case study, see if we have a case study to do. What would you folks like to do? Because for this particular exam, basically, it's keep every system or every condition to itself. Don't try to do a crossover.
What do you mean by crossover?
It was like we had the discussion about the potassium and the glucose, how they like each other, but then in Cushing's disease, they're opposite. So just make sure you don't group all people together. Does that make sense?
Yeah.
Okay. And don't try to just, if it's hyponatremia, it's not SIADH. You could be hyponatremic without SIADH. So that's what I'm trying to get at, making sure that, you know, we don't we don't cross over conditions and that we stick to where they are, or otherwise we're gonna be in for a whirlwind of trouble.
So, like in all of those fraternity initiations, where they drink a lot of water,
Yeah, water
what really happens to
intoxication.
them is hyponatremia that actually does the damage.
Mm-hmm.
When you get so much water as part of initiation process.
Right. So remember that hypervolemic hyponatremia. Remember, I said there's 3 different types of the hyponatremia. It's either your volume status is good, or your volume status is low, or your volume status is high. Remember that?
Mhm.
That's why I said that. But you're right. When you do have patients that or people that are initiating for sororities and fraternities, and we just had a kid just earlier this year with I think it was at either it's alcohol intoxication, but they actually had water intoxication. So they just tank down 2 gallons of water, and it basically just dilutes your electrolytes. It's no different than if you give a person too much IV fluids, and you can give a person too much IV fluids. So if you're thinking that you can't, yes, you can. Okay.
So, what is the quickest way to know when you are overloading the patient?
Lung sounds. That's your fastest way.
Because you'd start hearing crackles on the lungs.
Mm-hmm.
All right. Thanks, Mackie.
Yep. You just start hearing crackles. So that's why, when you're giving fluids, you need to check, and especially elderly. You need to check the elderly for overload, volume overload. Took me a minute to think of what I was trying to say, but gotta check them. And it can happen to anybody, but that's the reason why with kiddos, even with kiddos, they shut it down. You can only give so many fluids, because you can do the same thing to them. Give them too much fluids and boom. Now they have volume overload. All right, so I'm gonna share my screen. We'll try to put some of this stuff into practice. Where are we at? Share screen. I go all around this thing, and it'd just be right there in front of me with the little green arrow to say, here, share your screen right here, ding, ding. And share. All right, so we have a 65-year-old nausea, vomiting for several days following weeks of poor appetite and increased weakness. Blood pressure 90/50, heart rate's 120. They're complaining of nausea, vomiting, weakness, skin turgor. We have slight tenting of the forearms, tacky mucous membrane, so they're kind of thick, and decreased urinary output. BP is 10% drop from lying to a standing position. And they have 1+ peripheral pulses. So is that strong, weak, or what?
It's weak.
It's kind of weak. So based on that information,
I'd say they're dehydrated.
what would be your patient's fluid status?
Is that
A, B, C, or D?
Okay.
I'm wondering if there's a way. Okay. I agree. It would be A. So the correct answer is A. Okay. So which of the following, dang it. There we go. Which of the following collaborative orders are appropriate for treating this imbalance? Oh my goodness.
A, B, and C.
I'll do D2, right?
Why D? It is
Uh,
all of them. Remember,
yeah.
if
I,
it's dehydration, remember they're going to have confusion
Mhm.
because you said it was extracellular volume deficit, right? So they're going to have confusion because you would expect their potassium, their sodiums, and all of that to be low. So we want to monitor all of that. I'm just going to apologize for my phone ringing. I'm sorry. So which of the common crystalloid solutions will we use for treating a patient with the manifestations of hypovolemia?
B.
Wait, that's wait.
So Marky, you said B?
Yeah.
Okay. What do you think, Jenny?
I'm gonna say B.
Okay. So A is blood and head of starch. B
What's
is
starch?
head of starch is more of a protein, or it's a more concentrated volume of, it's not protein. I think it's a more concentrated volume of IV fluids.
I said B2.
B is normal saline and lactated ringers. Or then C is lactated ringers, blood, D5,
It's B. I
and
said B.
then D is blood, 5% dextrose water, and sterile water. So I would go with B as my correct answer. All right, scenario 2. So it's a volume expander, or that's derived from starch, Marky.
Okay.
So it's used to restore blood plasma through for patients that's had severe bleeding. So it's actually a volume expander, almost like a colloid, I want to say, than an isotonic. I was getting that confused with albumin, which is a protein.
Which that can be used as a fluid expander too, right?
Yes, it can. Albumin can be used, but head of starch is actually mixed in normal saline.
Okay.
So it's a plasma volume expander.
Okay.
All right, so here we have BC, 75-year-old with a history of mild heart failure. They're treating for a DIG. They're being treated with DIG, 0.125 daily, Lasix, 40 milligrams PO daily, and mildly restricted sodium diet, 2 grams daily. She is complaining of weakness, constipation, lightheadedness, a fluttery feeling in her chest, and dizziness. What electrolyte imbalance is most likely at this time?
Hypokalemia A.
Okay, do you all agree?
Yes, because of the diuretic.
Okay.
Agree.
All right, and you're correct. So the interaction of digoxin, diuretics such as Lasix and potassium may affect cardiac contractility. Which of the following findings should be reported to the healthcare provider prior to medication being administered? So A is pulse rate of 72, potassium 3.8, potassium level of 4.8, urinary output 100 milliliters per hour. Pulse rate 56 and potassium level 2.4, and potassium level 4.2 and urinary output at 70 per hour. So the easiest thing to do is look and see which one of these are abnormal.
Let's say B.
Urinary output 100 per hour is good.
I'll say C because
Yeah, potassium level.
it's 2.4 right there.
Even though potassium level is a little bit high,
On what?
on B, it's still less than 5.
I'd say C because the potassium level is already low.
It's 2.4.
Okay.
That's dangerous levels of potassium.
Okay. So
And the pulse is already low. Digoxin lowers the pulse, right?
Yes, that's what it says.
And remember, you have to check a pulse rate before you give it, and it
Yeah.
must be 60 or above in order to give it.
Mhm.
So, D has a normal K level and normal urinary output. So does A. Even though one's on the upper end and one on the lower end, it's still normal. Your answer choices, if you're freaking out, would be B or C, but because of the potassium level being at a 4.8, but it's still less than 5, and your urinary output's good. So by process of elimination, I would go with C.
Okay.
So, this comes up at the right time because it's stuff we just talked about. So kind of just to bring the point home. I think that's it.
Can we go up to the identifying the hypo or hyper, where we said it was hypokalemia? A 2 grams of sodium diet.
That's max.
That's not that bad. That's still including sodium. So it's not to say that they would be in hyper or hyponatremia, right?
But you would be on a sodium restricted diet because they have heart failure. So since she has mild heart failure, and mild as it may be, she still has heart failure. So we don't want to give her anything or do anything that's going to cause her to retain more fluid. Remember, water and sodium love each other.
Mm-hmm.
So that's the reason why I wouldn't go with hypernatremia, because, again, we're going back to the signs and symptoms that we've already discussed.
I think one of the major things I've noticed between sodium and potassium is that while sodium goes to the to the brain, that to the potassium goes to the cardiac, to the heart.
Mm-hmm.
So whenever I see anything like flutter, arrhythmia, my first thought is just to go to potassium. When I see level of consciousness and all that, my first thought, I'm not saying it's foolproof, but my first thought.
No, you're right about that, because remember in the beginning of the session, I talked about how it affects the cells everywhere, more specifically the brain. And then when you look at potassium, it's responsible for nerve impulses, and I said that earlier, nerve and muscle impulses. And then the systems that are usually involved is GI, heart, renal, lungs, and the lung muscles. So potassium is more heart driven. When, or going to have more heart concerns. So that's a good way of looking at it. So that's, so I don't disagree with it, but it's just hearing it a different way. All right, so it's 6:27. Unless there's any other burning questions, then what I'll cover in lecture will be SI, ADH, and DI. So we'll cover that first, and then I'll finish up the calciums. I think I have calcium, mag, and phos. I think those are the only ones left for electrolytes. Would that be a true statement?
Ma'am, can you do what you did last time? Like send us the last time you sent out some of the case study. The exemplars and all of that. Like for the last exams, you did it. You
talking about the raising the bars?
Yes.
You already have them. So you're raising the bar. Hold on. Let me just make sure. I've already done it. It should be in your course. I'm going there right now. And then I'll share my screen in just a second. And I know I've done it because some of my students have asked me, where's the one for coping? And I only have cognition and fluid and electrolytes. And I don't have any more after that. So I'm going to go to your course board because you're in the 1324, correct?
Yes.
Okay. So under raising the bar. Okay, so I'm going to share my screen. Hold on. Share screen. Yeah, share here. All right, so here's the key points, but here it is, fluid and electrolytes and cognition.
Okay.
So I've already done it.
Okay.
And if you're in 1533, pardon me, I did that last week, by the way.
Thank you.
Uh-huh.
Thank you.
They're right there, fluid and electrolytes and cognition. I don't have anything for coping, and I don't have anything for exam 4. So, you know, this was, I can't remember exactly, in the springtime, there was, right about this time, I think, I don't know if it was impatience or I don't know how to describe it, but the clinical coordinator or the coordinator, level coordinator, was, you know, getting them out and was sending them out, and then started receiving very rogue emails from students. You know, where am I raising the bars? I need you to send this to me right this way, XYZ. How do you expect me to be successful? And I was like, holy cow, I mean, it's not even a part of our curriculum, but at least she was nice enough to do it. And so she shut it down right at that point. I don't even think the 3rd level has any raising the bars post their 2nd exam. So, because I've actually looked around and asked a couple of faculty members, and they don't have them.
Sometimes a bad egg ruins it all.
Yeah. So unfortunately, you know, they have value, they really do, but I don't have anything post that point for 3rd level. So after exam 2, that's all they have. There's nothing for exam 3. At least you guys got it to exam 3, and, you know, unless Miss Johns decides she's going to finish them out, then. But I would follow the same pattern I'd follow the same pattern that I've already been doing.
Can you make an appeal to Miss John, or what do you call her name, to do it?
By all means, but you know, it's best coming from students.
What do you want? The letter group?
No, just send her an email and ask. You know, it's all in how you ask somebody about something. You know, I find the raising the bars to be extremely valuable. Is it possible for these to be completed? You know, I think it would be very, very beneficial to the students. And I mean, that's just the way to go about saying things. And I think it'll, you know, it definitely should go over really well. I don't see a reason why not, unless there's something that, you know, would prevent her from being able to do it outside of, and I mean something personal or something of that magnitude. So, I mean, just send her an email and ask the question.
What's her name again?
Miss Carol Johns. So when you go to your course board, she, you know, she has on there Mrs. Johns, 2nd level coordinator. So that's who you would send the email to. But I think the students just got a little out of control in the spring, and it didn't go over well. So it was not, as I said, not a part of our curriculum. It was something extra. And
Well, it's very helpful because it gives you like a targeted reading. So you know exactly what not to. If you finish reading, you can go back and say, oh, I missed this. I don't know what this is. I don't know what this is. Then you go back to the textbook to find out. It's very helpful.
I agree. I do not disagree with you. You know,
I feel like it helps organize our thoughts because we have so many resources that we can pull information from, and it really does. Like he said, if you see something on there and you say, oh, I haven't read over that yet, I can go research it more. Or
exactly. I don't disagree with it. Again, you know, it happened a semester before you. And trust me, when it all got shut down, the current J2 students that I had at that time that are now S1 students now, I mean, they were really distraught. So, you know, I mean, I can't blame them though. Right. I had no say so over that. And so now they don't have them for exam 3, because I was just wondering if she might have sent them out to anybody for that matter. But no, nobody has them anywhere. So for their exam, for the rest of their time, the rest of the semester, they have no raising the bars. So I agree, they're extremely valuable, extremely valuable. And it does focus and centers you when you're studying, which is the reason why she did it. But, you know, as I said in the last Zoom session, you guys should be doing about 30 questions a week in NCLEX with rationales. So not the adaptive quizzing, but the ones in your page bursts, your vital sources. There's a little NCLEX book. I would be doing questions in there.
What book is that again?
Hold on, let me see if I can find it for you. And you're gonna have to check and see if you have it available.
So we have 2 books that are real good to use. I know everyone refers to the HESI book as the green cover from previous semesters, but I think ours, that I have at least, mine is red. We have a red HESI book that's real good with questions that you can pick, whether it's med-surg or...
Right.
Is it either Evolve or you bought it from
It's
out?
an Evolve. I'm sharing my screen now.
Okay.
I'm gonna exit that. Okay, so when you go to Page Burst, do you know how to get to Page Burst?
Yes, I do.
Okay, so this is my personal Page Burst.
Okay. Okay.
So
Okay.
here's a comprehensive RN NCLEX. This is the one you're talking about, Marky.
Yeah, I like that book. And then the one 2 spots to the left, the
And here's a
Saunders.
HESI one.
Oh,
So
wow.
they're both HESI. One's an edition 4 and one's an edition 5. So
Yeah, that green book's just the older, but they're pretty much the same thing.
yeah.
The Saunders Silvestri NCLEX book,
Hold
that's
on.
a good one too.
And actually, when I think one of the earlier Zoom sessions, I had actually talked about some test taking strategies from that.
Mm-hmm.
My computer somehow skipped a page or skipped to something.
Mm-hmm.
Trying to see if nope. There it is. This one. The comprehensive review.
Mm-hmm.
So that's the newest edition. So you have some options. You have one here. This is the 6th edition, but here's the 7th edition.
Okay. Okay.
So
I use that Saunders Comprehensive Review a lot. It kind of cuts out the fluff,
right.
and I like it. And it's got some questions at the end of each chapter, at the each of, like, say you go over a couple gas exchange exemplars, it'll go over a few gas exchange questions with the rationale and.
Okay.
So
And this is very helpful. Good.
so this is what I would be doing to get yourself prepped for, you know, the HESI comprehensive, for the HESI exam. And then ultimately, well, you also have a comprehensive exam that you're doing, exam 5, it'll get you prepped for that. And then you have, you know, for your ultimate prep would be NCLEX. So,
Okay. Ma'am. Okay.
Yes, sir.
Yeah, for us, is the comprehensive final, is it going to be part of our exams, part of our grades?
I would have to look in your grade, look in your syllabus to see, because I don't want to put out the wrong information for the 1324 folk. So,
I know it was part of it in our when I did the LVM program just last.
Well, I know they did have an exam that was a part of their grade, but I don't know exactly which one. So until I know that for sure, I don't want to mislead anybody.
So 1533 and 1524 will have different grading syllabus?
Yeah, because they're actually 2 different classes. So
Okay.
they're, you know, although your exams are similar, very, very similar, your we have to look at the grading criteria. So if the grading criteria mentions that, you know, you will have your exam 5 is comprehensive, then you'll be taking a comprehensive exam. Does that make sense? But I just need to look at your syllabi. I haven't looked at your syllabi. So that's the only reason why I'm not speaking on it, because I don't want someone to say, well, you said in the Zoom session that we wouldn't have an exam 5. And I'm like, no. I don't know if you are. I'd have to research it and I'll give an answer on Tuesday, because I need to make sure I don't tell you the wrong thing. But I know unequivocally that 1533 will have an exam 5 and that will be comprehensive. So I can speak on that one freely. So, makes sense?
Yes, man.
All right. But those are all good questions. You know, they're very good questions because you need to know what's expected of you at the end of the semester. So, you know, I commend you guys for, you know, staying the course and, you know, staying on, at least coming every week to do the Zooms for those that are doing it. I mean, I hope it's helping you when it gets to the exam. You know, if not, let me know, then we can do, you know, we can change up what we're doing here.
No, I like how we've been reviewing it. Just my opinion.
Okay.
Not just yours. I share in it.
Okay. So, you know, just, you know, try to, if there's anything different that can be done, by all means. I don't think I have the magic answer. I have no crystal balls. So I tell people I'm all out of crystal balls, tarot cards, and I have no mind reading skills.
Can we also
I
ask the
think you're
questions on the pediatric, like if we have problems with the pediatric, my pronunciation.
Okay.
Pediatric part?
Pediatric. Okay.
Yes. Can we also ask the
I don't have a
questions?
problem with you asking the question about pediatrics.
Like,
If I
yeah.
can't answer it, then you know who I'm gonna ask, Ms. Pritchett. I mean, overall, I have a general gist idea about pediatrics, but it's her main expertise. You know, all of my expertise is ED, so you know enough about pediatrics, but to say I'm an expert in it, absolutely not. That'd be a lie. I'm truly an expert in adults.
Okay.
So, but usually for pediatrics, I can figure out what you're trying to ask and what you need to know and how to explain it. But I know she spent a lot of time talking about the different types of dehydrations that baby has.
I wasn't in class. That's why I'm just struggling with that. I couldn't make it Tuesday.
Okay, so what you can do is I can stop recording, and since it is 6:41, everyone that has other things to do, they can go ahead and leave the call, and then you can ask me your question. Unless, you know, go ahead and ask the question. Never mind, because I was like, no, I want to hear it. So somebody will say that. So go ahead and ask your question.
I don't really have them. I have to read first if I can have a question. Like all of those, I've been seeing them. I got notes from my friends. So all of those was ORT, was Pylorist. Okay, I'll remember next week. I can throw in some questions that if I find any.
Yeah. So if you have a question about it next week, then just or ask in class. If you have a question about it, just ask on the next session and we'll get it covered. But remember, Ms. Pritchett and I have you for about an hour and 15 minutes or an hour and a half. And then Ms. Chaudhry is going to come in and she's going to do the cognition and coping component. So you won't see us next Tuesday. We won't be there. We'll be there this coming Tuesday. So let me make sure that's clear. We'll be there on the 17th, but we will not be there on the 24th.
Okay.
Okay. So the next time we'll see you will be that Monday when you take your exam. That'll be the next time we'll lay eyes on you guys outside of Zoom session for me.
Okay, Zoom session is good. That's reassuring.
Do you know yet when you're going to do the next Zoom?
I've been trying to keep it on Sundays because that was the request. Sundays at 5 because the Cowboys was playing, but apparently this week they weren't playing. Hey, you know.
Yeah, I couldn't care less.
I like Sundays. I like Sundays.
I don't hate on them. I just don't really particularly care one way or the other. But you know, if
I will be on the call whenever you schedule it. I don't care.
So I don't, you know, make a big to do over it. The only thing I try to be mindful of is folks going to church on Sunday, and that's the only thing I'm really the most mindful of. So I don't want to impede your ability to, you know, go praise your God and everything. So I don't want you to say I couldn't go to church because no. So I'll do it in the afternoon, and so that way, you know, it's no big deal. But everybody wanted to go back to Sunday. We only did the Saturday because it was the exam. So next week I'll do a Sunday again, and then the week before the exam or the weekend before the exam I'll do a Saturday. to give you time to digest material on Sunday from Monday. So I'm trying to keep it consistent because once you start hopping all around, then it gets really confusing. So I just try to keep it either Saturday or Sunday.
No,
then
like
I
Marky
post-
said, I'll be there whenever, so.
Gotcha. So then I posted up anyway in your, well, we got too big, so I had to create a page for, create our own little page, DCCCD space J2 on YouTube. You just go there and the video's there.
Thank you so much for doing that.
Thank you for doing this, man.
No problem.
Yeah,
This
thank
is
you.
going above and beyond, and we're really grateful.
Great. I hope so. All right, guys, I'm going to turn it down because I need to do some statistics work and get all that turned in and talk about, philosophy that I really don't like.
Do good. Use your mind.
All right, guys, we'll catch up. We'll see you Tuesday.
Thank
Bye.
you.
Bye,
Thank
everybody.
you.
Okay, bye.